You see them? You see it now?
Yes.
All right. There we go.
Yes. Thanks, Bob. I'll mute myself now.
Okay. I don't know how much you were able to get from what Chris was saying because it was being broken up while she was talking with me. But to give you a little bit background myself, I've been working with SBIRT for over 10 years. As a matter of fact, we assisted, IRETA assisted in writing the grant for the Bureau of Drug and Alcohol Programs for the state of Pennsylvania, which Pennsylvania was one of the first states that was involved in the Screening, Brief Intervention, Referral Treatment Initiative. And what I'm going to be talking about today is I'm going to be talking about the older adults and that population. And what I want to talk about a little bit too is that over the years I've worked with SBIRT, there's all kinds of different populations that are now being served. At the very beginning, we were looking at those 18 and above. But over the years, as SBIRT's progressed, we have gone into adolescents, we have gone into colleges, universities, when I was here in Florida, we specialized. We were in cohort 3. We specialized in the older adult population, 55 and above. And for those of you that know me, have just turned 63. I am an older adult, and it's real uncomfortable a lot of times when you're looking at definitions. There are departments of elder affairs, older adults, so there's different terminology and different definitions going on out there. So the one thing that I've learned in our field after 39 years is that you have to have a sense of humor. And especially as you get older, you've got to be able to laugh at yourself. And so we're going to start off, especially for those of you who had an early lunch this morning, I'm sure. Just got done and you're sitting there, and hopefully I'm going to be able to keep you awake for the next few hours. But we're going to start with a little bit of humor. First thing, the successful agent we know is the ability to be able to laugh at ourselves. And let's take a look at Mildred. Mildred says that turning 50 is like visiting an all-you-can-eat buffet. What should be hot is cold, what should be firm is limp, and you'll notice the buns aren't very fresh. Okay. Another one, Mildred says, good news, people are living longer than ever. The bad news is we don't get to choose which people do live. So today's presentation, I'm going to be talking about the types and the extent of substance abuse in the elders arena. I just have to move this screen out of the way. There we go. I'm going to be talking about also the SBIRT initiative throughout the country, as well as what we did in Florida, because in Florida we were specifically working with the older adult population. And we're going to be talking about some of the screening tools that you can use with this population and how effective it has been when using the kind of screening tools that we do. Also the approaches, we're going to talk about approaches to enhance motivation, to reduce change, and use of these substances, which these motivational techniques some of you have probably had, and what we focus on is what we actually use when we're doing SBIRT in either the medical setting, or it could be working with senior centers. We also have in-home services. So we're going to be talking a little bit about different models that can be utilized, especially when you're working with the older adult population. All the information is evidence-based. We use validated screens. A lot of the screens over the years have shifted from one to another, then back to the original one. But basically we're going to talk about the ones that I think are very useful that I've used in the last 10 years that can be very effective, especially working with the older adult population. And we're going to talk about implementing the SBIRT services within the aging services in perhaps your communities. Okay. That didn't work. So let's take a look at some of the definitions. We're looking at the Social Security Administration definition of what old is. Old they consider is from 55 to 64, which when I first read this, when I was 53 years old, I was a little upset. Look at the elderly. They classify elderly 65 through 74. The aged is 75 through 84, and very old is 85 plus. We're finding out today that based on a lot of different things, medication, attitude, lifestyle, people are living to be a lot older now. And when you're talking about working with older adults or you're working with geriatric populations, first comes to mind to a lot of people is a person that has a lot of dementia, the person that is not physically active, the person that is depressed a lot, and that's not true, especially with the population that you're going to be working with SBIRT. Here's some other definitions of young, old, relatively healthy and active. They may not be retired. Another definition that's out there is old, some disability and decline in functioning. They may be assisted to grow old in peace. And there's old, increased incidence of chronic illnesses, disabilities, also referred to as a frail elderly. This is going to be different from the different communities and the different states that you live in. In Florida, where I live in now, and I lived in Pennsylvania for a while, the populations are so different. Down here where I live in a community of over 100,000 retirees. It's called the Villages. We have like 28 executive golf courses, 11 championship golf courses, 200 swimming pools. Some of them are sports pools, tennis courts. These people are very active. When I first came down here when I was about 55, I was playing tennis with gentlemen that were in their 70s that could hit the ball faster and harder than I could. And I was a USTA 4.0 tennis player. So these are very active communities. Maybe in other communities where you may live or where some older adults are, they don't have these type of activities. Basically, they stay in their high-rise apartment, and they may go to the senior center for services. They may do some church activities or whatever. So there's different populations that you're going to serve when you're working with SBIRT. It's not going to be the one that is always on the far end. But as we look at as we're really looking at this, for some reason my slides were changing automatically all by themselves. So I'm trying to take control here as I talk. Every day in our life, be active your way. Like I said, there's different levels. As you hear people say that the 50 is the new 30. You know, so it's basically health is very important as a motivator when you're working with the older adult population, which when we get into motivational techniques, we'll be talking more about that. The problem that we're dealing with when you're dealing with the older population is that, first of all, they're grossly underserved. You're looking at the services for 55 and under is grossly underserved. Approximately 5 persons receiving service for every 100 people that really need services. Older adults don't seek service in traditional service settings. That's why SBIRT, when we get into talking more about the SBIRT, is so effective because we know older adults do go to their physicians. They go to the emergency room. And the one benefit of using SBIRT and using SBIRT in the general setting is that, and from my experience, you almost have instantaneous rapport with that person that you're setting in at the emergency room or in the doctor's office. And we're going to elaborate on that a little bit later. The barriers to older adult cases are unique to their population. For example, a lot of places in Pennsylvania, even here in Florida, have public transportation. But there are a lot of counties and a lot of areas that don't have that type of public transportation. So as people get older and they need that, and we're talking about getting them to services, it's really difficult. So you have to be really creative. And in the training that we do with SBIRT, training healthcare advocates or educators, is talking about alternatives and seeking out those kind of alternatives. Also, there's some national trends that are out there going on. As we know that Americans 65 and older will double within the next 25 years. And by 2030, there's going to be over 72 million people that will be 65 years and older. That's close to 1 out of every 5 Americans. And again, a lot of this is because people are trying to live healthier. The medications that we have now, mortality rate, as you know, has increased both in males and females. And by 2050, you're looking at that seniors will approach about 90 million. And as you can see, those that are going to be 85 and 100 and older are there. I'll give you an example. We have a close friend. She's going to be actually coming out at the end of this month with Willard Scott on today. She's going to actually have her picture. She turned 100 years old. In the last probably year, she's been in the hospital twice for heart problems, but she's been out. Every time we think she's not coming out of the hospital, she's back, and she's stronger than ever. She takes the bus, she goes to church, she's active in her community. So this is the trend that's happening out there. People are living to be a lot older, and a lot of the problems is people are outliving, especially for the older generation, outliving their spouses and sometimes their own children, which becomes a real problem. And we're going to be talking about that as we go on. So when you're talking about more patients 65 and older are admitted to hospitals for alcohol-connected problems than for heart attacks, that's something that really people aren't addressing. And when we're going to be talking about the different type of drugs that the older adult uses, we know alcohol is one of the major ones. We're talking about a lot of pain medications, a lot of prescription medications. When we first started with SBIRT back in 2003, a lot of the effort was basically looking for alcohol and illicit drugs. They weren't looking at prescription medications, misuse of prescription medications, mismanagement, over-the-counter drugs, which basically those are important. And then here in Florida, we were able to add some of those questions along with our other evidence-based questions to assist us in finding out about the prescription medication, and we'll talk about that in a minute. So there are more patients that are being admitted to nursing homes. About 1/4 of nursing home administrations occur because patients are unable to manage their medications. Proactive drugs used directly causes up to 14% of hip fractures. When we're talking about the nursing home, when they go into nursing homes, they have to do a nursing home a nurse's assessment within 24 hours. My wife, for a while, when we came down to Florida, was assistant nurse, a nursing director at a progressive retirement village where you go from your apartment into assisted living, then into a nursing home there. And you'd be surprised that when they do the assessment, some of these older adults are on 20 to 30 different type of medications and through several different doctors because no one was asking them or they weren't talking about their prescriptions. And some of the questions when you go to, for example, I went into an ER here in the community, and this was a few years ago, and the only question they asked me was, do you use alcohol? I said, yes. Do you use any illicit drugs? I said, no, and that was it. They weren't even concerned how much alcohol or about any other prescription medication or over-the-counter drugs I use. And I could be drinking a fifth of Jack Daniels every other day, and here I go see a physician, and he prescribes me benzodiazepines, which is very serious. And so some of these questions that are now being asked through SBIRT should have been asked a long time ago. Psychoactive drugs indirectly cause up to 14% of the hip fractures we're talking about. A lot of people become dizzy, uncomfortable, they're falling more, and automatically a lot of people assume it's part of a dementia issue. They're not even thinking about perhaps maybe they're misusing their medications. Also, some of the other barriers to identify older adults with substance use problems is ageism. We're talking about society's negative stereotypes. We don't look at the older adults as having a problem with that. And then we often say, oh, they deserve to drink a little. They've earned it over their lifetime. It's also internalized by them. And there's also a very big lack of awareness by professional society, family, and older adults. We're still training physicians in addiction issues, even today. When I started as a drug and alcohol counselor back in 1972, I thought this was being done, and we started back then, but it's still being done today. Also, clinicians having an understanding of the older adult issues, the major grief and loss issues that they deal with. There's a change in their body, their metabolism, especially when you're talking about drugs. And as you know, their tolerance is decreased as they get older. And they're using much more medication than really what they should be using. Also, training of clinicians in this area. And physicians. A lot of time physicians are really uncomfortable when older adults come into their office. They like to deal with them real quick and get them back out of their office and move along to the next person. Some other barriers are, again, the clinician behavior, the amount of time spent with the patient, discomfort about raising issues. A lot of people think, well, they're too old to change, so, just let them go ahead and drink and do what they do. They're 80 years old, maybe they've got 5 years left. I mean, these attitudes are still there and still prevalent today. And it is difficult. I remember years ago doing some drug and alcohol groups in a nursing home, and here you have a paraplegic and other people sitting there. You're talking about the use of alcohol, and they're saying to you, look at me, what are you talking about? You're going to tell me now I'm going to need to cut back on my drinking? Forget about it. And it's really tough working with that. But again, we're going to be working with varied population, working with people like yourselves, those of you that are 55 and above that are out there listening to this, and myself. When we go walk in and we listen to a doctor asking us and talking about why they're asking and how important it is to their medication that they're going to prescribe for me or the treatment they're going to prescribe for me, I'm educated. I'm going to listen. Again, your population is going to vary based on your where you're living and the activity level of your seniors in your community. Also, comorbidity issues. This is a little difficult. Substance use problems are mistaken for other problems. Schizophrenia for years have been, especially with cocaine and other issues, have been misdiagnosed. So that's a problem. So why is it difficult to identify the alcohol and drug problems with our older adults? Again, like I said, they have a decreased tolerance because of age. Our metabolisms change. We don't metabolize things as easy as we did before. There's that feeling of shame, stigma on the part of the older adult about what's going on with them. They don't want to talk a lot about it. A lot of them even think they're falling, and their dementia is based on them getting old and have no idea that it could be the alcohol and the overuse of their prescription medication that they're using. So again, it's very important for them to be educated. This is what SBIRT is doing out there. Effects of alcohol and other medications mimic other medical, neurological, emotional, and psychiatric problems. I just talked on that very briefly. Living alone, this is a big one. There's no one else there to observe the adult. And even if there is, especially with their children, you know, they don't want to deal with the issue. They say, so she drinks 3 or 4 drinks. She's not hurting anybody, so, you know, as long as there's no problem, I'm not going to say anything or do anything about it. The significant others, particularly, again, the adult children, their reactions to the alcohol or the drug use. And so what's so funny, too, is that we have a lot of services that are provided to older adults in their homes. People go in, they're looking for food, cleanliness. They don't even think about looking in the medicine cabinets or in the freezer to look to see how many cases of beer, or if they have a lot of prescriptions in their medicine cabinets that are so outdated. And just over the years, I've started to educate, adult protective services divisions in different states, making this as part of their intake, using the valid screens that we use for SBIRT can be utilized in their screening and giving those individuals training. So that's another area where you can utilize the SBIRT is in your adult protective services of your state. The common reasons for not helping, again, been drinking all her life. He's too old to change. She's too old to change. And that's not true. As a matter of fact, I could teach people to change as long as they have the want, the desire to, they can change. But you have to find out what motivates them. So we're going to be talking about that. Drinking is the only pleasure that they have left. And so why depress them or take away the thing that makes them happy? And the doctor says that a glass of wine in the evening is good for the heart. So that may be. So the person thinks, oh, so if one's good, maybe two's going to even be better. So this is some of the way that they think. A drink is better than a sleeping pill. I don't like to use pills. Just like years ago, people say, I'm not an alcoholic. I don't drink all the alcohol. I only drink beer. Also, they drink to relieve their pain. The doctor would have said something if it was that bad. Well, again, a lot of times the physicians, people aren't asking about their use of their alcohol or medication in the doctor's office. And years ago, even still today, and a lot of practices use the cage. And for those of you that are addiction professionals know, the cage was developed to find those people that are completely dependent. Okay, do we really want to find just dependent people? We want to find people before they get to that point so that we can do these interventions and we can educate them and help them improve their lives. So let's look at some general incidence and prevalence that goes on. This population of approximately 35 million people, you've got there are at least 3 million with alcohol and drug disorders. This is what the federal government estimates. And the Center for Alcohol and Substance Abuse, CASA, Columbia University, estimated that the population of women 60 plus alone, there are actually 2.8 million psychoactive substance use abusers. When you do your research, when I did my research, and also my experience working with the overall population, you're going to find a lot of the drugs that they're using are the Vicodin, the pain medications, the synthetic narcotics, the tramadol, other medications like that. There are people that are misusing them, they're abusing them, they're doubling the amount they're taking not to. But then also there's older adults out there that are cutting their pills in half or in fours because they can't afford the medication. Okay, come on, computer. There we go.
Okay.
There we go. Okay, alcohol and substance abuse estimates to older adults who need addiction treatment is estimated to triple by 2020. And this is going to be a problem if we don't address it now, because as you know, with budget cuts all over, the first things that they want to cut is Medicare, Medicaid services, and you're looking at the substance abuse services. So what we have to do is we have to be creative, and I think the SBIRT is a very creative intervention and an alternate program that can be utilized for the older adults as well as you know, for anyone actually. So let's take a look at it. Here's a profile of someone that might be typical. Here's Jim. He's worked hard for 45 years. He looked forward to retirement. His wife's deceased, depressed. He has children that live 1,000 miles away, numerous aches and pains, indigestion, medications for nervousness, can't sleep nights, watches TV and drinks in the afternoon, drinks more in PM, hates getting up in the morning. Okay. These are the type of people that aren't going to walk into your agency, social service agency, for help, or they're not going to walk into the local drug and alcohol program and ask, will you please assess me because I think I may be drinking or whatever. But they do go to a physician's office, or they do go to the emergency room. And so this is vital, again, why SBIRT is very advantageous and very important when working with all, but basically when we're talking about this population specifically. And what we have to do is we have to train the physicians, interns, nurses, social workers, everyone in this concept of it's okay to be asking about this. It's like asking about diabetes, it's asking about asking about their heart disease. They need to start asking about this. And what we did over the years with the programs that I've worked in, the states I've worked with, assisted in developing what we call a extended health care questionnaire, which is put on the paperwork when they come into the ER, or we actually use them in urgent care centers. They complete that, and it has the evidence-based questions that we score and tells us what kind of intervention is needed with that individual. And it's given to the patient to fill out. And if it's given to them, it always has a paragraph explaining why we're asking these questions. This is a healthcare question. It's related to use of alcohol, prescription medications, and over-the-counter medications, because we know it may affect the treatment that the doctor may prescribe for you. That is very important. And this is confidential between you and your doctor and us, and blah, blah, and it works very effectively. Very little resistance when you use it that way. And when I do the mentoring with people that I do train, I tell them I've gone in and I've introduced myself. Hi, I'm Bob Hazlett. I'm part of the healthcare team. I don't go in and say, hey, I'm Dr. Bob Hazlett. I am an addiction specialist, certified clinical supervisor, all this, and I'm going to be talking about your use of drugs and alcohol and prescription medications. That's not going to work that way. You have to, do some ego checks and whatever. You have to be part of that healthcare team when you're in that primary care service or generalist service, so that you don't put a barrier up right away. I had the opportunity, for those of you who know, that SBIRT actually has been there way before 2003, before SAMHSA and CSAT got involved in it. For example, Project Assert, Dr. Edward Bernstein's program. Some of you are very familiar. I had the opportunity working at IRETA getting started back in 2003, 2004 to actually spend 4 days with Dr. Bernstein and his staff on the unit. And using their techniques, I assisted in an intervention, and I walked in, introduced myself. Within 5 minutes, this woman told me her whole life story. And we found out that she was pregnant, she just moved to that area, she needed some other services, and that she was on drinking and using illicit drugs, etc. So right there, the staff was able to help her get some assistance in some of those other issues. But if I walked in there and introduced myself and I was an addiction specialist or I'm a licensed mental health worker, it'll create that problem. And you need that kind of rapport in that quick-paced setting to get to the point. Well, that was Jim. And look at here. Okay, come on. There we go. Here's Mary. She's another one. 82 years old. Her husband's deceased. Lives in senior subsidized high-rise. Social Security check barely provides enough to live on. Takes numerous medications. Children call each week long distance. Nervous, depressed, and she gets her relief by getting together with the girls and the community and having cocktails and trying to forget about her problems. So these are a lot of the ones that you find in areas. We found a lot of these in the areas in the Pennsylvania area, in the areas where they have high-rise senior living programs, but they don't have any type of activities for the seniors. So they sit there and they think about all these issues and all these problems. Here are what we consider the characteristics of alcoholism in older adults based on AMA and ASAM criteria. Generally, you're looking at peer-controlled over-drinking, preoccupation with the drug alcohol, continued use in spite of adverse consequences. That's not just for the older adults. That's generally for a lot of people that are having that problem. But when you're looking at addiction for older adults, the onset of continuation of the alcohol really problem is because of the physiological or psychological changes in their lives. Everyone has grief and loss at times in their lives, but as you're getting older, you have a much more friends, your people that you looked up to that were your elders are gone, and so there's so much of that happening. And we're finding a lot when we're working with them. We have a lot of seniors that are widowed. Their husbands have passed away, and now they're back out in the workforce again, and they're trying to cope, and because they really can't afford things now, so they're back out there working. I go to a restaurant where there's a lady that's 85 years old, and she is wonderful. Very quick. She's better than a lot of the waitresses there. She loves her job there, but she had to go back to work at 85 because she wasn't able to make ends meet. So we're looking now at what some of the areas that we're going to have for assessment. The medical problems, we're looking at physical distress. The physical distress problems will be, you'll find those are the ones that assist them in getting help. A lot of people in certain neighborhoods are very close. We have people that from church recommending people to come to certain services. There's the chronic pain issues. They're dealing with a lot of that as they're falling, getting older, and they're going to, again, to their physicians and to the emergency rooms to get taken care of. Also senior deficits, a lot of problems with their vision and hearing. Makes it even worse, especially with their medication management. When we train some of the healthcare educators, we train them on how to get them help as far as, for example, there are certain med boxes that actually talk to the individual, telling them what time it's time for the medication, things that they can put on their refrigerator to help them visually. We work with the families. So these are some of the kind of issues that you're going to be dealing with. And you're probably looking in our community, maybe 6 seniors walk through the door of the ER. You're looking at probably 1 to 2 out of the 6 have these kind of real problems on the far end. The other ones are ones that have maybe been very still physically active, maybe between 55 and 65 still. So again, it depends on the community and who you're serving. Okay, when we're looking at older adults and medication use, we talked a lot about the alcohol. Let's look at the prescription drugs. 85% are on a prescription drug. 76% use more than one drug daily. 20% use tranquilizers daily. Largest consumers of psychoactive drugs, we know that. Also, older women, 60% of all their prescription medications, over-the-counter medications. 70% use over-the-counter drugs daily. Adults 65 plus use 3 times as many meds as those under 65. I know I'm 63 now, and I use a little bit more medication than I used to. And I'm very aware of what I use because of the field that I'm in, and I'm very careful about the medication that I use. Older adults, older patients average 2 to 3 serious med errors per month. They're very forgetful. They forget about taking them, so what they do is they take them again, or they take 2 doses. A lot of them try to take all their medication in the morning so they don't have to remember during the day to take their medications. So there's all these kind of issues that are out there that are facing the older adults. And again, that's why it's real important if you're working with the SBIRT is to move into those areas of working in the prescription medications and over-the-counter, as well as the illicit drugs and alcohol, because these are the issues that they're dealing with. You'll see a lot of my neighbors are on pain medications. I just had a reverse shoulder replacement, and I'm on some light medications for the pain. But I'm using physical therapy to counteract that so that I can reduce my pain medications. Also, older adults, some of the other issues that we're talking about, that over 65 use 3 times as much medication. We know that there are medication errors, and at least 40% don't follow prescription directions. That's the issue. Even I remember my mom sitting around talking with the neighbor lady saying, oh yeah, I've had a headache for a while, and I said, well, I've got some of these special things for sinus headaches that the doctor gave me. Here, why don't you try one of those? Or that they try each other medications. They save medications up for later on. And as you know, the shelf life of medications differ. So this is one thing that's really important. If somebody's going into home doing an investigation looking for food, they need to look in the medicine cabinet and look at their medications and see what kind of medications they're using. This could be the reason why the person was called into the agency, because they fell. Maybe they're having their 2 or 3 glasses of wine and using their tramadol or some other pain medication to go along with that, and then they go outside and they fall. So, that's an important part of what agencies do when they're working with older adults, is to incorporate these screening techniques into their intake process. A reason why seniors often do not take the medications prescribed, again, they forget about it. Also, they double up. They take the medications in the morning so they don't have to worry about sharing medications, save medications. I just talked about that just a minute ago. Some of the factors increasing the risk of medication, multiple diseases, multiple issues. You know, when a person has this and not realizing the doctor says, well, here you need to take this aspirin, but you need to take it after you eat. That's a larger dose aspirin, and you know, I want you to take this twice a day. So what they do, they take it before they eat. So these are some of the things that we have to deal with. Language barriers, multiple drugs and complex medical regimens, the types of drugs that they're taking, again, the decreased tolerance. You know, they talk to me, I'm 63 and the doctor's giving me this and I'm taking 325 milligrams of maybe, say, Percocet, and the doctor only prescribed them a much lower dose, and they're at 85 years old. And they go, oh, Bob, he takes 325. There's no reason why I can't take 325. So they double their dose. But again, their tolerance is much different. Problems with intervention with the older adults. There's a sense of shame about having negative personal information shared with others. But you know what? It's different when they go to the doctor. They want to talk to the doctor. They share more with their physician than they would share with their kids, with the social worker that comes there being sent by DCF or whatever. Living alone, significant others may have little information. There are so many people in the community that we live that I know that some of their kids drop their parents off in this wonderful retirement community and down here in Florida, and they may be lucky to come see them once a year and maybe call them once a week, but they don't know what's going on with them at all. They don't have a relationship with the neighbors or whatever, so it's really difficult. Geographical distances, sense of shame by the adult children about parents who's drinking or drug use. Okay. Some of the problems of intervention with older adults continue. There's an unwillingness of significant others to participate. That happens even when they're not that age. We find that's a problem. But as they become older, it's even more so. Lack of adequate reimbursement for treatment. Again, the treatment issues, and again, they're looking at trying to cut Medicaid, Medicare again, and we're constantly in the battle of trying to fight for that, to keep services for the older adults. Lack of appropriate treatment resources. They throw older adults in with younger groups and talk about the issues they're dealing with the younger groups and have no idea about what the older adult population is dealing with. Taking financial care of children and also parents, issues of possible inheritance. You know, I hate to say that happens a lot. There's a lot of battles within the family, especially who's going to get what if we put them into the hospital, what's going to happen to our inheritance, blah, blah, all this kind of things go on, and that's reality. And the one thing also that I want to talk about, and we're going to be talking about what we did here in Florida in SBIRT, the one thing that's really important is the depression issue. We were one of the first states and the second cohort to actually address the depression and start using the short version geriatric depression scale as one of our screening tools, initial screening tools. We found that there's persistent sad moods, loss of pleasure and interest in activities once enjoyed. We find also sleep disturbances, too much, too little, appetite problems, irritability, restlessness. All these signs and symptoms of depression are there. And it could be created because of the drug. We're not sure of that. But the issue is we need to find out for sure. So part of what we do is we screen for that. Depression and suicide risk, especially in older population, you can see clinically depressed mood is associated with 83% of elderly suicides. And that gets to the point where, especially when excuse me for a second, especially as they lose their spouses, they're losing a lot of their friends, they're feeling all alone, depressed, no one's reaching out to them, their kids have no understanding of that, they're into their own lives. Also, patients who have had multiple episodes of depression are at greater risk for suicide than those who have had a single episode. These are facts. Lifetime risk of suicide for individuals with untreated depressive symptoms is approximately 15%. Okay, so with these statistics that are out there now, I think it's a vital. It should be a must to go ahead and screen for the depression when you're dealing with the older adult population in the SBIRT process. So the suicide in the older adults, one of the leading causes is the depression is undiagnosed and untreated. The act of completing suicide is really preceded by only one cause with one reason, and the only common risk factors include, again, recent death of loved ones, physical illnesses. It's really difficult to deal with this. I know I've had back, my own self, I've had back surgery, now I'm having this arm surgery, and you know, you're confined to your house for weeks upon end, and when you're in a chronic problem, it works on you mentally and spiritually. So the holistic approach to working with a person is important, and we talk about that when we do some of our training with SBIRT. Also perceived poor health, social isolation, loneliness, major changes in social rules. And this is from the American Association of Suicidology. And there's at the bottom of the screen you can see the website if you want to look into more about this. So depression in medical patients and the older hospital patients, 6% to 44% are diagnosed with major depression, with an average of about 12%. It's higher among those with severe illnesses and chronic illnesses. Other depressive diagnoses among older hospital patients range from 18 to 26%. We're looking at mild to moderate issues. So the scales for screening older adults, there's cognitively intact patients ages 60 and above. The short version geriatric depression scale is one of the best validated screening measures that you can use. It has about 15 questions to use, and it's very simple. We put a lot of these screening tools in a tablet where in a program that it can be automatically scored as you ask the patient these questions. Other scales out there which have mixed results are the Beck Depression Inventory, the SESD, which is from the Center for Epidemiology Studies, the Zung Depression Scale, and patients who have a lot of cognitive effects, the Cornell Scale, or the informant version of the short geriatric depression scale can be used. These are some of the ones that you have to choose from, but the one that I have chosen and have used with many states and with assisting in many states is that short version geriatric depression scale. Or the other one is the PHQ-9, which is the patient health questionnaire. Some of you are familiar with that. If you're not, PHQ-9 was devised for physicians to use to help them look for mental health issues, and it undercovers a lot of the issues that we're talking about with depression and suicide. PHQ-9 is there. part of our screening tool that I'm going to be talking about, we use the PHQ-2, which is 2 questions out of that, as a preliminary, as a pre-screen questionnaire for depression. Okay, so before we continue, I just want to conclude a little about the depression issue. Depression is a common in the older adults and is very serious, and I think if you're looking at doing the SBIRT project, I would incorporate the screening tools for the depression. Like I said, the 2 that we use are the PHQ-2, which is a pre-screen, which could lead to the PHQ-9 or the short version geriatric scale. So 2 questions is not that much to add to your 6 or 7 question pre-screen that you may be using. Most older adults are not screened routinely. They're not. A lot of times the family don't recognize the signs. Most depression goes untreated, and also, those who receive treatment are more likely to be treated by the physician than a mental health professional. So this is where we're going to get into talking about SBIRT, Screening, Brief Intervention, Referral, and Treatment Initiative, and how it's utilized not only throughout nationally, but also how it can be utilized to work with the adult population that most of you signed up to hear about. The SBIRT, as you know, Screening, Brief Intervention is a very brief, preventative measure. It provides the screening tools that are evidence-based, and based on the scores of those screening tools, a brief intervention can be provided, or what we call an extended brief intervention, which is called brief treatment, and also referral to treatment. And we're going to get into that more specifically here in a second. Come on. Okay, this is the data that's gathered from SAMHSA. Basically, over the cohorts that have already worked, we're talking about, it's way up over the 900,000 people now have been screened across the U.S. By SBIRT sites. Reduction in alcohol and drug use 6 months after receiving intervention is 41% of the response reported abstinences from drugs and alcohol at the follow-up, compared to just at recent baseline. As you can see, that's very effective. And it's probably even more effective because the follow-up that we did over the years has been very minute compared to what you might be doing as an agency, because it's just a small percentage of those individuals. Like, for example, in states it was if your Social Security number was between this and that, and you were positive, you were going to get a 6 months follow-up. Well, you're looking at maybe you screened 100 people. 10% of those, based on statistics, 10 of those 100 people are positive. And maybe 1 person out of those 10 might have that Social Security number you're looking for. So, but based even on that, like I said, this is still impressive that we're getting that much individuals. And it probably would be higher if we would do more follow-ups on more people. Improvement in quality of life measures, including employment, education, status, housing, in 30-day past arrest rates. 95% reported no arrests in the past 30 days of follow-up, compared to 88% at baseline. Also, reduction in risky behaviors, including fewer unprotected sexual encounters. Injection drug use decreased from 3.2% at baseline to 1.5%. These are all really great reasons for the SBIRT, and that's one of the reasons why SBIRT is one of the projects that have been, luckily, have been funded every year since 2003. And they know the importance of this problem and the people that we're reaching. We're talking about over 900,000 people that would never have been reached before, because we moved this into the generalist setting. As you take a look at this map here, that shows you the different colors on there, shows you that there's over 20-some states that are involved in SBIRT now. And as you can see, the little diamonds are colleges and universities. The stars represent the tribal organizations that are involved in this. It was so funny when I first got started, and there was only the 3 or 4 states, which was up there in Pennsylvania, where we were at there, and now look at this project. So we're reaching more and more people, and it's vital that we continue the SBIRT process. So the SBIRT initiative is an evidence-based, it's federally funded model. It identifies persons at all levels of alcohol and drug use or dependence. Okay, it provides brief interventions, brief treatment to patients who are misusing alcohol and other drugs. And when it first came out, a lot of us had discussions with SAMHSA, CSAT, and because I come from the old form, when we say treatment, treatment means treatment. But this brief treatment we're talking about is an interim to your traditional treatment modalities for substance abuse. And it's something that people can be trained in doing, physicians, nurses, people with maybe a bachelor's in education. It doesn't have to be a seasoned mental health worker. Sometimes that's a problem, because I've had to do mentoring. 39 years, I'm not a clinician at heart, but I was able to adjust. But I had to do mentoring because a lot of those people were sitting down instead of doing screening of a lot of people there in the ER. They were sitting down, they were looking for people that were dependent, and they were sitting down there trying to do therapy with them. And while they were doing therapy with the one people, 30 to 40 people left that emergency room that could have had some education or some brief interventions to assist them so that they don't become into that dependent area. So we had to try to re-educate, which it worked out well. We were able to do that with a lot of people. And also, you have to realize that if you're getting involved, with SBIRT, it's very fast-paced environment. We had people that had to leave SBIRT because they couldn't handle the blood and the gore. You're working in an emergency room where there's a lot of activity, and you have to move from one patient exam room to another exam room. So if you're thinking if you want to sit down there and just be a therapist all day and talk for hours, it's a different type of setting. There is a need for that when a person needs to come back for another intervention, which could be up to 45 minutes. But while you're doing that, someone else is out there screening, and there's ways of implementing this that can be very effective in a fast-paced environment, which I can help you with that if later you want to contact me to discuss that. So screening patients who are probably alcohol, referring patients who screen high for possible alcohol and other drug dependency or depression to specialized treatment programs for assessment. This is what SBIRT is. These are the core components of it. It is a screening component. We use pre-screens, especially in emergency rooms, trauma centers, because you're seeing lots and lots of people. You know, when you're seeing 100, 200 people going through a trauma center, you need to be able to screen those individuals out and focus on the ones that you're going to need to work with as far as positive for brief interventions or referrals. So again, there's the brief intervention. It's followed by a screening result indicating the moderate risk. This involves motivational discussion. We teach basic motivational techniques. We also provide them later on for more advanced training on this, but some very quickly brief motivational techniques are very effective in a 5 to 10, 15-minute session. Then the brief treatment model, this is a person that if they come back and the brief intervention didn't work and they're not being able to be successful at a reduction plan or whatever, they need further work with them, using more cognitive modalities with them and more intensive motivational. We call that brief treatment sessions. Now, for some reason they can't do that. They need to be referred on after 1 or 2 of these brief treatment sessions for a further assessment. you need to be able to refer them to a treatment facility. And what we do with the SBIRT, especially we're working here in Florida with the older adult population, or in your population, anything 18 and above, if they score in that moderate level for both alcohol or drugs, or along with the depression, we send them to a more co-occurring disorders program so that they can be assessed for all. Okay, if it's just the alcohol or whatever, we'll send them to a substance abuse treatment program for that. So these are basically the components of the SBIRT. What I'd like to do right now, we're going to be talking about medication misuse, and I'm going to be talking about how we do the SBIRT with the older adult population. As you can see here, this could be me asking him, "Hey doc, can you write me a prescription for some of that Viagra?" And my wife saw this and she says, "No way." She thought this was cute, so I thought I'd share this with you. But what I'd like to do right now is we're going to take a break around 1:30 to about 1:45. But right now it's 1:15. So I'd like to open it up now for some questions before we continue on.
Hi, Bob. This is Chris. Thanks so far. I don't have any questions yet.
Chris, you're coming in broken up, Chris.
Oh, sorry. It's got to be my phone. I don't have anybody who's typed in any questions yet.
Okay.
I have someone named Lee with the hand icon raised, but I can't unmute that person, so maybe they can type in a question. But so far I don't have anybody who has any questions or comments. So
Okay.
if it would be a good time to break, you can do that now if you want.
Okay, why don't we then take a break till 1:30 then? How's that? Okay?
Yeah, it's up to you if you want to break now or, go through another topic.
Yeah, we'll break now.
Okay. Okay, so it is 1/4 depending, I don't know what time zone everybody's in. So we will come back at 1/2 And during that time, I will mute our phones so you don't hear any background paper shuffling or whatever. And also during that time, it would be great for you to type in your questions that you might have for the first half. And we'll give those to Bob when we return. So thanks, everybody, and take a 15-minute break.
Unmuted.
Hi, Bob. Bob? Bob, are you back from your break yet?
Unmuted.
Hello? You ready now, Chris?
Hey, Bob, this is Holly. I think
Yeah,
Chris will be right on.
Bob, I have a couple questions here if you'd like to address those before we move on.
All right.
Okay. The first one, let's see, is asking about numbers regarding how many older adults have been screened using SBIRT.
How many number of older adults using SBIRT? I know here in Florida we were first do it, and all I know is what we're doing here in Florida. We have screened over 90,000.
Okay, thank you. And the other question is asking you to revisit the slide with the original drug alcohol use. I think it is possibly slide number 36, the data from SAMHSA. I'm thinking it might be there. Because the person thought that the 3.2% for injection drugs was very high to begin with, and she was wondering what your thoughts are.
Okay.
And that's on that slide number 36.
All right. Let's see what I can do here.
It's right after the SAMHSA slide.
So right here, 0.2% baseline to 1.5% follow-up.
Yeah, I think that's the one they're referring to.
Okay. You want me to start with that one then?
Yeah. Well, no. The question is just concerning that that they thought that 3.2% was very high.
Yeah, you know, that was high, and it was from baseline, okay? And I think the problem with it, why it's like that, is that when they go to the follow-up, the amount of, for example, how I said before, why is this changing? Let's see what
Are you you're either hitting the forward button or the if your cursor's down in the lower left-hand corner of the slide, it could be there and advancing them.
You know what it is? I've got to take out this. Okay, got it. Okay. When they do the follow-ups, basically doing the follow-ups, is that the follow-ups is only a small percentage of the people that were actually screened. And so when you're looking at 3.2 people, you're probably looking at very few, but then it's based on the follow-up of those few people. For example, we were getting, it would be different than if you do a follow-up on 10% of everyone that was positive, okay? But that's not what it is. It's how SAMHSA, how it has been, it's a certain number, last two digits of a Social Security number. They're changing that, but now it's still the same as, like, for example, ours was like from 2.3 maybe to 2.9. Okay, so we did a baseline on maybe 5 people. Out of those 5 people, there might have been maybe no one that had the 2.3 through 2.9, so there wasn't a follow-up on that. So I think when it says the injection drug use decreased from 3.2%, that's high, because it might have been maybe they checked with 1 or 2 people and that was it. You know what I'm saying? The amount of people that they did follow up on wasn't that high. But it made the number, when you look at, oh wow, this person really reduced, and here it's 3.2% based on maybe one person they did the follow-up on. So that's where I'm getting at. That's how I perceive it.
Okay.
Because it's something that we've discussed every year, is that you know, clinically, from a lot of our standpoints, is that we're not following up on enough people, and they're not having us follow up on a lot of people. They want to make sure that we follow up on the people that do screen positive, but when you're using those numbers to get your numbers to do a follow-up on, it's very few. You might have screened 100 people, and out of those 100 people, the way the statistics are, 10% of those individuals will probably need a brief intervention. Okay, out of those 10%, maybe there was the one person that had those risky maybe two people had those risky sexual behaviors, but only one of them had that Social Security number, so you would only follow up on the one person, not on both of them. So, but at baseline, you had a different number.
Okay. I have a comment about that slide, too, that just came in. They're saying, in addition to what you're saying, it might be useful to reiterate that it's 3.2% of the group of people who screened positive. It's not 3.2% of the general population.
Right.
Okay, that answers the questions. You can go back to where you left off now for the second half.
All right.
Thank you, everybody.
Okay, so here we're looking at medications use for older adults. 85% are on a prescription drug. 70% use more than one drug daily. 20% use tranquilizers daily. The largest consumers of psychoactive drugs are the older adult population. I went over this briefly before, I think, about the older adults, and at least 40% don't follow prescription directions. One study indicated about 90% of the people do not follow up. So what we had to do is we had to change our approach to substance misuse in older adults here in Florida, and a lot of other states have contacted us, and I've worked with other states that are interested in doing what we have done in Florida. It's basically the SBIRT initiative. The only thing different is the people are trained in what kind of issues the older adult population deals with, but also using certain screening tools for that population. So we, again, Florida changed this idea, because when I first came down here, Florida applied, like when we applied in Pennsylvania, we got the grant in the first cohort. Florida did not get it in the first cohort. But what they did is they decided they took $600,000 out and they put into 3 to 4 programs in the state of Florida to provide screening and alcohol treatment in the homes of the elders. Like, for example, Broward Senior and Veterans Division was one of them. Another drug program was one of them. Another senior service program was one of them. And so when they applied for the grant in the next cohort, we got $14 million. Okay. And then they hired me to come on board, and what they were doing is, when they were looking for providers, they went with the 4 original providers that they had, And basically what I explained to Florida is that's not going to work because they're going to come back because you're not screening and seeing enough people. For example, the Broward County Elders Division maybe screened 15, 20 people out of the whole month. Okay, and I said, you know, they're going to come back and, you know, talk to you about it. And sure enough, they did. They came back and said, and I told them you're going to have to be in the general settings and you're going to have to do direct contracts with them. So they gave me the authorization to get on my horse and go throughout the state of Florida and, you know, negotiate and get these kind of services. So during that period that they had the $600,000, that was a 3-year period, and they actually screened and serviced only 1,400 people. So changing it over to the format of what SBIRT really is about, and we got direct contracts. I was able to get contracts with the Miami Hospital, VA Hospital, one in Broward, the Miami Memorial Hospital, down in Palm Beach. We got urgent care centers. We also got senior centers also. Senior centers, we got mobile units. We had physicians that were doing physicals and going into communities, low-income communities. We got them involved in doing that. So we went from those 4 sites to I ended up with 28 contracts with over 75 sites throughout the whole state of Florida providing SBIRT services. So in that time period, they wanted us to do at least 66,000. Well, what we did is we exceeded that. Within the 5-year period, we exceeded over 80,000 people, so I was really happy with that. But in 2011, we continued to also screen 3 or 4 of those programs began screening the 18 and above. But anyhow, this is what Florida did. It had $14 million for the 5 years, which was nice because I think in Pennsylvania, Holly, or Chris, we only had something like 11. I think it was 11 million or something. But anyhow, but again, the positive screen typically followed by 1 session of brief interventions. In our contracts with our providers, we allowed up to 5 brief interventions and up to 12 brief treatment sessions before they either had to be referred on or discharged. And the BRITE just focuses the same thing as SBIRT does, but on the problematic use of people 55 and older. We first had 60, and then we talked to SAMHSA, Eric, and them at SAMHSA. They decided we moved it down to the 55 and older population because of the type of retirement communities we have here in Florida. So in 2010, we did have some agencies and was able to fund some agencies to continue to do the 18 and above. The substance abuse program, out of children and family circuits, that's where we were. We had the money and we oversaw the program. We implemented a general community program, standardized evidence-based screening documents, involves the automated performance measurement system. We used our tablets. We used our program on the tablets. Some of the urgent care centers put them exactly on the computers. As you know, a lot of now when you go into the emergency room or whatever, into the waiting rooms in the areas, they have computers in every room, so they just type all that information on and it scores it. Only BRITE project, SBIRT grant, that's specific to the older adults, we were the first ones. Offered in medical, behavioral health, substance abuse services, and aging services. We, again, went from 4 counties to 19 counties and up to 75 different sites. So we screened for alcohol, illicit drug medication, and depression. Okay. Now these are the specialist providers that we use. In agency services, we use women's services, treatment services, veteran services, family services. They used health fairs, senior centers, senior housing, county health departments, other community settings. And so if you're out there and you're thinking about getting involved in this, and every state has their adult protective services, this would be a good way to initiate your SBIRT when you're going into the homes and using the screening tools to go ahead along with the other intake paperwork that they do and make it part of a health assessment while they're there. The general settings, we had emergency rooms, trauma centers, urgent care clinics, walk-in clinics. We had, here in Florida, we ended up with 4 federally qualified health centers doing the BRITE project, the SBIRT/BRITE project. And these were the 4 areas when we first started. And then these are the contracts that we have now in the state of Florida. And we're going to be talking about continuing those programs. When in 2011, we were able to continue like in Palm Beach area and also in Broward County area with their senior services. There was other funding sources available there to continue besides the money from the Substance Abuse Programs Office in Tallahassee to fund those. And what was nice in Palm Beach, the commissioners felt that it was such a great project that they just absorbed the SBIRT budget from the county senior division there in Palm Beach, and they took on the responsibility of its funding, which was really great. So those were some of the ideas that we were able to use after the dollars were gone. We incorporated the screenings into the normal routine in the medical and other community settings. For example, after the money was gone, especially in the urgent care centers, we had 5 urgent care centers in three different counties. What they did is they made that part of their intake. They put the screening questions on a form that is given to the person when they walk in that door. The person fills it out. It's scored by the person at the desk that receives this information, and then it's put into a file, whether it was positive or negative, and that file was had a little dot put on it, so when the medical assistant, whoever went into the room first, examining room with the patient first, saw that, and then continued to ask the screening questions. The pre-screening questions were the ones that was in the extended healthcare questionnaire, we called it. And then the screening tools that once they saw the dot was the assist, which I'm going to show you that in a minute, the alcohol, smoking, substance abuse involvement test, and the short version geriatric depression scale was also administered. So here are the questions that we utilize and you can utilize. This is the anti-AAA. When we're talking about the quantity frequency, we're using, and what we did is we're using it instead of the 60 and older, we're using it for 55 and older. So we just geared it for that. So again, instead of the 14 drinks for men over 55 and for all women, it's 7, and then the daily maximum is 3. So as you can see, if they exceed that, then they're trained to go ahead and administer the assist and the SGDS, short version geriatric depression scale. The pre-screening questions, now those pre-screening questions are the screening questions that we put into the extended health care that I talked about, that ER rooms are using, urgent care centers are using, given to the patient. Okay. Other places they're using these screening questions and they're asking the questions. Okay. Especially the in-home services and the senior centers. are utilizing them, especially if the social worker is providing the screen and is considered the healthcare advocate there. The first two questions are about the drugs. The two questions, they have a 93% negative predictive factor, meaning there are going to be 7% of the patients with substance use disorders. So if they say yes to either the first two questions about drugs, then they are automatically going to administer the assist. The other two questions are the PHQ-2 questions. They come from the PHQ-9, which is the patient's healthcare questionnaire that physicians use and a lot of medical facilities use, and some of your senior services use. And basically, if they say yes to one of those two questions there, then the short version geriatric depression scale is used. So from pre-screen to screen, yes to alcohol and other substances, the BRITE staff administers the assist screen. If yes on either the depression items or the depression scale or the 15-item scale, then basically they are considered mild to moderate, and they're given the SGDS. Now the alcohols, we chose the alcohol smoking substance involvement screening test for a couple of different reasons. One, it was highly recommended, as you know, it was developed by the World Health Organization, WHO, by an international team of substance use researchers. It's found, it's been used in many different cultures, a very culturally sensitive document. It's very effective, and it finds the things that we're looking for. It finds for people that are into misuse, it's finding people that are very high risk or moderate to high risk, and it finds people that are dependent. And the other thing that it does, you have to read the assist. You can go to SAMHSA's website, you can pull up the assist, and you can look at it. It starts out, it asks about the prescription medication, okay? And it says that if for some reason you're using your prescription medication for a different purpose than what it was prescribed for by your physician, or an amount more than what was prescribed for your physician, please tell us about that. So they talked about that. And you use the audit and the DAST, it deals with, again, it deals with the alcohol and it deals with illicit drugs. For all populations, we should be looking at the prescription medication as well as over-the-counter drugs. But when you're working with the older adults, it's specific. You can need, I mean, it should be a requirement by everyone to be talking about their prescription medication and over-the-counter medications. Now, the assist, the very first question, basically, there's only 8 questions in the assist. Again, this is also put into the tablet and can be scored on the tablet, and the tablet will tell you what the score is and what the brief intervention is. It's very useful to put these on the tablet and help with the healthcare educators so they know exactly what kind of intervention is needed for that person, especially when you're training. Like, for example, we have medical assistants doing this. We even have EMTs doing this, nurses, physicians. We even have an X-ray technician that's involved in doing some of the brief treatment modality because they really enjoy doing that. And those are some of that are working in the urgent care centers. So the first question basically asks their use of any drug in their lifetime. Then the second question just narrows it down to those drugs uses in their last 90 days. So that kind of focuses on either on down to 1 or maybe 2 drugs, sometimes 3 drugs. With the older population, you're usually we're finding again the alcohol, and we're finding the pain medication and those kind of medications that you use. And then the third question talks about in the past few months how often had a strong desire or urge to use, and it asks other questions pertaining to that and their behavior, things like that pertaining to it. And the very last question asks them about their injection of drugs other than for medical purposes. Okay, so when you look at the assist, I think the assist is a very good screening tool to use for the adult population, and actually for the 18 and above. That's kind of my recommendation. A lot of the other people that have been using the assist also too. And when you're working with the adult population, again, it's prescription, medication mismanagement of medication, and those things, and over-the-counter drugs. And like I said, as you know, those of you that have been working with SBIRT for a lot of years, it took a while for us to ingrain that into them, that we need to be doing more than just illicit drugs and alcohol. We need to be doing more with the prescription medication and with the over-counter medications. So that's the screening tool. The depression screening tool, again, here's that PHQ-2. Little instrument of pleasure in doing things, feeling down, depressed, or hopeless. It's a yes to either question and follow up using the PHQ-9, a 9-item self-admitted questionnaire. Now, in Florida, we use the SG, the short version geriatric depression scale. In other states, when I first did some training in New York, I don't know if they're using that now or not, but I trained on the PHQ-9 because they were doing all ages, and I thought the PHQ-9 would be more suitable for that. So here we have the short version geriatric depression scale. We were the first state to add that depression screen to the SBIRT. Approximately 75% of the patients, clients that we screened positive for substance misuse abuse experienced the mild to moderate depression. If they said yes to the alcohol or substances and yes to depression questions on pre-screening, we completed the assist and the SGDS. If no to all drug, alcohol questions, and yes to depression question, then we just completed the SGDS on the individual. Now, again, this model can be used in your states or wherever you're from if you want to incorporate it. But we have a lot of senior centers where they come for the day. They get meals, they have an activity therapist there, and if need to, they see a nurse or a physician. We had a lot of those up in Pennsylvania at the time, so I'm not sure how Holly can probably talk about that in the future, whether Pennsylvania has been working to get into those kind of senior centers. They are perfect because the nurses can screen, the social workers are there can screen, can do the brief interventions. So getting involved in that would be very useful. And in your state, again, there's all kinds of avenues. Senior care centers, nursing homes, assisted living. We had one of our drug programs. What I had to do, I had to work really hard here in Florida. It took me close to 6 months to 8 months, but I did it. I was able to get our drug treatment programs into hospitals with working agreements and memorandum of understandings where they were working in the ER. And one place, the hospital actually gave them a use of a computer in a room to do the return visits. So those drug treatment programs are still in 3 major hospitals in the Fort Lauderdale area, and they're also in federally qualified health centers. And again, like I said, a lot of people continue this. Now, when we're talking about brief interventions, the brief intervention, or what we call also brief advice, is usually just a single session immediately following a positive screen at the moderate risk range on the assist. It consists of a motivational discussion with the patient, discussion focused on increasing insight and awareness regarding the impact of the substance use, and also maybe the referral to a specialized substance use treatment when it's indicated. Important considerations for when you're doing interventions with older adults is you need to be able to avoid the labels. And this is with everyone else too. It's not just with older adults, but it's more prevalent when you're working with older adults. Avoid confrontation or anger. Create a safe environment. Avoid shaming, which includes avoiding attempts to get older adults to express feelings. Be non-judgmental. Connect use and symptoms. And connect behaviors and participants' emotional responses. Relate alcohol and drug use, abuse issues to how it can affect the health. And that's what we do. We iterate when we do the training that we want to make sure that we relate it to the health. They came into that generalist setting, or they're doing a health fair, you're doing a health fair, or whatever. So you're inquiring a little bit about their health, and so you ask the questions and you explain to them that these questions are asking about your use of medications, both illicit drugs, alcohol, and other medications. The reason why is it can affect the treatment the doctor's going to prescribe for you. And our health is your main concern. Do you mind us asking you a few of these questions? Again, you're probably getting maybe 1% resistance from people, especially the older adult population. And we're finding that we get a lot of feedback from the older adult population. They really like having someone in the exam room to talk to. Because sometimes it takes 15 to 20 minutes before the physician can get into that exam room. Okay. So relate the alcohol and drug to why they're there. Some of you have already had motivation. I'm going to go through this very quickly. Motivational intervention is broadly defined as a clinical strategy designed to enhance client motivation for change. Money motivates people. Like I said, you're never old to change. If somebody said to me, I'm 63, I'm 75 or 80, and says, hey, Bob, I'm going to give you $100 more in your paycheck if you, every time I see you, you cross your arms the opposite way. I'm going to practice like heck to do that, so every time I see that person, they'll see me being able to cross my arms a different way, so I can get that $100. Some people are motivated by presents, rewards, or whatever. But we're finding more people, especially in the community around where I live here, where there's over 100,000 here in the villages, and there's more because they're building more homes. They're motivated by their health. I'm motivated by my health because I like to do things. I like to play golf. I like to play tennis. I like to do this, to do that. And if I go and see the doc, and the doc says something about what I'm doing, my behavior can be interfering with my health, which can interfere with my golf swing, I'm going to listen. And so health is a big factor with a lot of the older adult populations. So relating their misuse of medication, or we're talking with a lot of people, they might be only drinking 1 or 2 more drinks than what they're supposed to during that week. We're finding it very easy for those people to be able to say, hey, that's no problem, I can give up 2 drinks. And so we check with them in another 2 weeks, and they say, oh, that's no problem, I'm only drinking the 7 for the week. Actually, sometimes I only drink 6 now. Well, that's really great. And then you discharge them from your SBIRT, program after that couple weeks of, talking with them. And you're going to find, it depends on where you're at, like in Miami, the Jackson Memorial Hospital is involved. Their ER is like an auditorium. It is filled constantly. And it's filled with a lot of mental health people in there, a lot of addicts in there trying to get meds and medication. So every area is going to be a little bit different with the type of clientele and how the screening is going to take place. And if you're seeing 200 to 300 people in that ER, you're going to want to do the pre-screening, use the pre-screening tools. Next, I'm going to show you a very brief intervention video that I've used. This doctor has been trained in motivational techniques. He has a very good manner about him. We'll talk about the positive, or I'll talk about the positives after you see it. But I want you to check your clocks because you're going to find that this intervention is done within 4 to 5 minutes. That's all.
Okay, Joe, let's see what we got here. You had a pretty bad crash. Do you remember what happened?
I remember leaving the bar. The rest is pretty much blur.
So you're unable to read because of being in the bar.
Yeah, I guess so.
Sounds kind of frightening. Would you mind if we spent a few minutes talking about your drinking?
My drinking. What about it?
Well, help me understand what drinking does to you. What does it enjoy about it?
Look, I work hard during the week, and having a drink or two after work helps me to relax. I mean, our guy says to cut loose every once in a while. I mean, my friends go out a lot, and I like to hang out with them.
So it's a way of relaxing and enjoying being with your friends.
Yeah.
Well, I can understand that. Everybody needs to unwind. Now, are there any things that are not so good about your drinking?
Not really. I mean, I have trouble getting up some mornings, and I can't think straight for morning some days.
Doesn't make work more difficult.
Yeah, I mean, the day starts out kind of hard, but I just, stick it out, try to push a little harder.
Sounds tough. Are there other drawbacks to drinking?
I'm crashing my car is kind of a drag. I need the car. And having to get sewed up like this isn't too much fun.
No, I imagine not. We're just about to here. That should do it. So, on the one hand, drinking is a way for you to relax and enjoy doing it with your friends. On the other hand, it makes getting up in the morning more difficult. Wrecking your car and having to be stitched up in here, well, those are other pain consequences. So where does that leave you?
I guess I can cut down, the drinking a bit, especially on the week.
I think that sounds like a terrific idea. Have you ever tried anything before?
Yeah, I've done it before. I can do it on my own.
You know, Joe, some people can cut back, but for some it's difficult. We find that having more than 14 drinks per week, or more than 4 drinks on any one occasion, puts at risk for some serious problems, not to mention injury or illness. If you find that after 4 weeks drinking more than that, well, then my medical opinion, you better put some outside help. I'm glad to give you the names and numbers of people who you can speak to. Now,
a good idea. I suppose I get a time. Thanks for your help.
Okay, as you can see there, this doctor did very well. He used the motivational techniques of the pros and cons, asking what's so good about his drinking, what's not so good, relating it to his accident, getting him to think, not judging him, not calling him an alcoholic. His tone of voice was excellent. And these are the techniques that we train our healthcare advocates to use, because all the time it's going to be the physicians doing the brief interventions. So it's going to be a medical assistant or a PA or whatever. So, or it could be the person was hired with a bachelor's degree in psychology or education that was trained in that exam room asking the questions and doing exactly what the physician did. So So that's basically what a brief intervention is. Okay. What's brief treatment? It's following a screening score of the assists of 20 to 26. We worked with SAMHSA on this. It was anywhere from 19 up to 27 could be left open for a decision whether you'll do the brief treatment or refer them, but they wanted a more specific cutoff. So this is what we used. If it's 20 to 26, the brief treatment modality is utilized. Much like the brief intervention, it involves motivational discussion, client empowerment. In our motivational training that we use, we train them to talk about what are some of their life goals, what are their goals that they're working on, and then kind of show them where their behavior is keeping them from those type of goals. And a lot of cognitive models are being used during that time period. And then the BT, like I say, is more the comprehensive, includes the assessment, education, problem solving, coping mechanisms. We even have given them homework assignments, forms that they can use with the patient there, and some forms that the patients take home with them. And it depends on the situation. When I assisted in implementing, we do what we call the business process analysis plan. When I go into the facility, I always make sure that they're going to have more than one person in that ER that's going to be doing screening, because we talk about the brief intervention, the brief treatment, because if the patient is going to be coming back for an additional session, what happens is we set it up that the one healthcare educator or medical assistant or whatever there is there, that's her day that she, Monday through Friday, Monday, Tuesday, and Thursday and Friday she's doing screenings. But on Wednesday is the day that she sees the people for that 20 to 25 minute return session, or it could be up to 40-minute return session of brief treatment. While the other one's out there, her days of screening is Monday, Tuesday, Wednesday, and Friday, and her day to see people is on Thursday, return people, so that the other person is out there screening. So again, it's always making sure that that's covered, because there's a lot of people that go through those ERs and those trauma centers. Okay. The referral to treatment with the assist. When the scores of the assist are 27 and above, the individual is referred for a complete substance abuse assessment by substance abuse provider agency. Again, we were referring them to them for an assessment. We're not saying there, I'm diagnosing you, unless it's the physician wants to do that. I'm diagnosing you as you may be an alcoholic, so I want to send you to it. No. We're saying based on your scores, you're very high risk, and we would like to send you to this provider to do a full screen on you, an assessment on you, just to see where you may need, because it seems like you need to have some help with this. And if for some reason they don't want to go, and they say, I'd rather come and return and talk with you. Well, in Florida, we allow it to happen, but with the idea that we let the person know that our goal here is to get you ready to go for that further assessment, because that is not what their job is right there in the ER, okay, to do that. So scores of 27 on the assist and high range on the SGS, automatic referral to an assessment at a co-occurring DO program, because we want to make sure that they're being assessed for both not only drugs and alcohol, but also for mental health, depression, etc. So who Who are the BRITE providers? Who can they be? Well, they can be hospitals, ER, urgent care, federally qualified health centers, able to screen larger numbers for BRITE SBIRT services, or they could be smaller programs. They can be your local senior centers. I know some senior centers, they have up to 150 members, and then when somebody leaves, they allow somebody else to come in to be part of that program. So that it could be smaller. It could be, like I said, health fairs, the mobile health units that are doing, physicals in the neighborhood, traveling. It also can be nursing homes, progressive programs. You can train the nurses in nursing homes very easily because they do a whole package. I mean, they spend hours with these people when they first come through the door. They have their 24-hour nursing assessments that they have to do. So selling this to them would be something to do. When I work with the physicians of the urgent care, I really like these physicians. They can make the decisions quicker because a lot of times hospitals have to call their boards and they have to do this and they have to do that. But these places are owned by the physicians, and one physician owned 3 of them. And after the money was gone, we had to put it on our plan. They said, we're going to continue this. We're going to go ahead and bill, Medicare for it, but we know we did that. We had them bill it, and they only got like $20, $25 or something like that. He says it doesn't matter. It's the right thing to do. That's what I really like to hear from physicians. It's the right thing to do. And they were using the cage before, and they saw the purpose of doing this. And so, again, sustainability, using the CPT codes, current procedure terminology, additional codes for reimbursement of services. That's the main purpose. When you start in with the SBIRT, you need to work on the sustainability as soon as possible, and what the sites that you're getting contracts. They really want to sign up with you, especially if you're the state entity and you're offering them $150,000 to $200,000 a year for 5 years. They really want to sign up. They want to really be part of this, but you need to find out at the beginning, well, what are you going to do to continue this after the money is gone? This is what is available now, but what are some of the resources that you can come up with? And we've been very lucky. A lot of our programs have been very creative. A lot of the counties have been able to absorb the funding sources. As you are aware of the VAs involved in this, when we first got started, VA had to screen everybody for alcohol and stuff. And then when we got involved in this, they found this to be very useful. Now, in the Miami VA hospital and in the Fort Lauderdale, they are screening. They have their emergency department for the older veterans. They're using the screening tools there. Then we have our adult protective services people trained in doing this when they go into the home. They're not getting any additional monies for that, except for their program monies that they're getting. They made that part of their intake package. Senior daycare centers. We have some busy nurses associations that we train. I've even trained on my own time some Catholic Church programs that they have counseling services, and they wanted to be part of this, and so they're doing that in their parishes. Senior and veteran services. If you have senior veteran services in your community areas, they were really great. Who can provide what kind of staffing? Healthcare educators. We call them healthcare educators or advocates. Physicians, residents, RNs, LPNs, medical assistants, EMTs, social workers, substance abuse counselors. We work with some colleges. Some of the counselors are involved. We've also did some high schools where we trained some nurses in the clinic because the kids come in because they got a runny nose or they fell down, they got hurt, and part of their intake package is the screening tools, especially for the adolescents, train them in the craft, and those type of screening tools. Substance abuse counselors can do this. Now, just to quickly to show you what the BRITE results were here in Florida, you can see our targeted after we met with, when they came back, SAMHSA came back, and I told the state of Florida this is what's going to happen. We started doing it. They allowed me to go out and do this, and they wanted us at 66,000, which was the targeted. But we did 85,000, and we had referral to treatment. Out of those was 916, 682 for brief treatment, 6,489 for brief interventions, and screening and feedback. We gave feedback to 76,000 individuals, and it seems like it's a small amount, but actually it's in reference to what SAMHSA is telling you, because out of the people that you screen positive, you may have 10% for the brief treatment, brief intervention, and maybe out of those 10%, 2% of those people are going to be referred to treatment. So will SBIRT continue after funding ends? Well, like I said, we have programs that the state was able to fund, the Substance Abuse Programs Office to continue in the going 18 and above. We have counties that have absorbed the budget funding. We have physicians and hospitals that are still involved. We have the University Hospital, Hollywood. We have Tampa General Hospital. We have all the urgent care centers. We have the VA hospitals still participating, and they're using their own dollars to do this, which is really good, because right now the reimbursement codes for screen brief intervention, CPT codes, some of you are familiar with those codes and have been using those, hopefully. The Medicare G codes, the Medicaid HCPSC, the H codes we call them. You're using those here. Basically, you can see what they are and what some of the prices are. I don't know, Chris, if my little menu is covering up some of the numbers or not. But anyhow, those are the reimbursements for that. Now, the only problem is with this, and those of you know, SBIRT was developed so that it can be used by most anyone. It doesn't have to be a licensed physician or a licensed mental health worker, social worker, or whatever. But with the way that Medicare and Medicaid in some states are set up, those are the only people that can reimburse for that. They're working on that now. Eric Eppenrud, Dr. Eppenrud, and other organizations are working to try to get funding for programs, so that if you're a substance abuse counselor, that you're doing this, that agency can get reimbursed for that. But there's other codes that you can currently use. Now, there are some problems. Some of your third-party insurance payers are paying for this. Some aren't. We found that when we first started doing this, we had some of the physicians doing a pilot, letting them take a few of the patients and not putting it into the SBIRT, but putting them in for the Medicare reimbursements, and especially using third-party insurance. The problem is when the patient gets their in the mail, you know, when you get yours from the like Blue Cross Blue Shield, it has, this is not a bill, but it shows what it billed. It has not only a code, but it has substance abuse, you know, procedures and that on it, which some of the physicians got called from. I wasn't there for substance abuse. What's this all about? So they had to do some explanations on that. So there's a lot of work that still has to be done in that area of reimbursement. So what's the next steps? Well, for Florida, again, we were able to fund them through the Substance Abuse Programs Office, or using the Medicare reimbursement right now. Our problem here is, like in other states, they both have the Medicare and the Medicaid codes turned on. We don't have the Medicaid codes on, even though we're supposed to have. We don't have the money to do it. Plain out, that's the fact. We don't have the money, and that's the problem. We're having all these seniors here in Florida, one of the retirement cities. Everybody comes down here to retire, such as me, and needing all these services, and they're cutting back, and they don't have the budget for this. So, but the next steps apply the SBIRT model to other populations, young and old, more veterans. I know in your states you have your local VA programs you can use, or maybe your county programs you can use. Improve the science and identify prescription medication misuse for older adults. University of South Florida, some of you heard of Dr. Schoenfeld. Dr. Schoenfeld and I, we've talked about this for a long time. They were the evaluators, and actually he's maintaining our website for us, which I'm going to give you that information here at the end, how to get that information. But you know, we've been putting together some things to work on just looking for that prescription medication and mismanagement use. And I think there has to be more focus on that, especially when you're dealing with the older population. Work with state policymakers. I was really happy when I first started. I started doing some training in New York, and they had the governor's drug committee there, and one of my presentations, and we sit down and talked, and they had both the Medicaid and Medicare people. They wanted, how many sessions can we? They were ready to fund. I mean, it was very, very apparent that they were very for this project, and they said, well, how many do you want to pay for? Recurring sessions, you know. So, so all these things have to be looked at. And the key to successful SBIRT, whether it's for older adults or for all populations, is to have a really good, if you're from the state, have an active state steering committee where you can get on board some of your third-party payers on board as part of the committee there, working on these problems, working on these issues, working on the funding. That's very, very helpful, and I think it's very vital to your success when you're initiating the SBIRT program and initiative. The other thing, too, before I get into this, that's very important. I don't know how many of you states are out there that just came on board with it, and that you are the individuals responsible for monitoring your providers and doing the contracts with your providers. Do not let the GIPR forms hamper you. That was a problem when we first got started with this. They're very long documents, but I was able to, in Pennsylvania, but also down here in Florida, able to, I wouldn't say manipulate, but able to introduce the GIPRAs at an ideal time in the intervention and be able to train the people on how to get these GIPRAs completed without a lot of negative feedback and from the client. But those GIPRAs are time-consuming, but there's ways of getting around some of that in the training that you do with the big GIPRA forms, with the interventions that you do. So again, don't let those detail you. For those of you that don't even have to worry about the GIPRAs, that's great. This is a no-brainer program that when I talk to physicians that that aren't involved in the SBIRT, and I tell them what we're doing, the Florida's on, because I'm no longer with the state of Florida because the funding sources have dried up. I'm officially retired, and I'm a consultant working with other states and working with the with IRETA again, the national SBIRT ATTC, which I'm really proud of that and really glad that IRETA and the ATTC got that. They deserve it. We did a lot of work at the very beginning with SBIRT, and they continue to be, along with myself and others, the experts in this area. So that's so much as far as the next steps. There's a lot of information that I'm trying to get to you within the 3-hour period of time, but I think I covered it. I'm going. Before I open it up to questions, I want to leave you a little bit with some information where to get other information, but also I want to lighten it up for a little bit and take it from the serious mode to a little bit of laughter. Again, I'm in this retirement community, and we send jokes among us all the time, and here are some of the I think are cute jokes. I'm not here to embarrass or anybody, but I think these are kind of funny, and I want to share them with you, and hopefully you'll share them with other people that you think will appreciate them. First of all, old is when my sweetie says, "Let's go upstairs and make love," and I answer, "Pick one. I can't do both." I hope I'm getting some chuckles out there. Old is when a sexy woman catches my fancy and my pacemaker opens the garage door. Also, old is when getting lucky means I can find the car in the parking lot. And here are some senior personals that you might find in our senior paper. We have our own newspaper, large newspaper down here in the villages. Mint condition, a male, 1932, high mileage, good condition, some hair, many new parts, including hip, knee, cornea, and valves. Isn't in running condition, but walks well. How about this one? Foxy lady, sexy, fashion conscious, blue-haired beauty. Slim, 5'4", used to be 5'6", searching for sharp-looking, sharp-dressing companion, matching white shoes, and a belt, a plus. I still have white shoes. What are you talking about? That's not bad. Okay, here's where you can get some of the information I talked about. CSAT Treatment Improvement Protocol tip number 26, substance abuse among older adults. Also, it's available free from the National Clearinghouse on Alcohol and Drug Information. You can contact them at 800-729-6686 or at www.health.org to order. Okay. Now also, SBIRT BRITE project, for more information about Florida's and working with the older dogs, so you can go to http BRITE at the Family Medical Health Institute, the Florida Mental Health Institute at usf.edu. That's where Larry is, Dr. Schoenfeld. He maintains our website there, and you can get data and information off of there. You can visit the National SBIRT ATTC, IRETA, which is putting this training on today, at ireta.org/ATTC, or you can email me, Robert W. Hazlett, Ph.D., at rhphd@embarkmail.com. So at this time, I'd like to go ahead and open it up for any questions.
Hi, Bob. This is Chris again. I just had one person ask if you could talk about the expanded version of BRITE.
Okay, the expanded version. Okay, what we did is the expanded version of BRITE. You mean as far as going from working with just the older adults to the 18 and above?
I think that's what they're referring to.
Okay. Yeah, what we did is we provided three urgent care centers. Also, we have the Tampa General Hospital, the University Hospital. We have 4 federally qualified healthcare centers. We have 2 substance abuse programs that are embedded in other hospitals. that we can, State of Florida, continue to fund as long as the money's there to provide those services. They're programmatic money used directly for that. Some of the programs get anywhere from $75,000 up to $150,000 a year to continue the services. What we have done is just expanded the tools. Instead of just using the short version geriatric depression scale, they're using the PHQ-9, especially for those 18 and above. The Urgent Care Center has, two of them have worked up memorandum of understanding agreements with local technical colleges to do screenings with their people because they have a contract to go in and to maintain the medical office at the tech centers. So they're in there doing that, but they're screening the 18 and above. As far as what the data is on that, you would probably have to contact the Children and Family Substance Abuse Programs office, since I'm not working there now. I know some of the people still there. We have some communications with them. If you want to email me, I can email you back with maybe their phone numbers and their names so that you can contact them to see what kind of data that you can get from them now, because they started this in 2011. And from my understanding, this is 2013, they've still been able to fund them up to this year, and hopefully they'll be able to next year. That's the information on that, on the extended BRITE project.
Okay, a couple others questions are coming in now too. Can you talk more about having people come in or for follow-up brief treatment? And what types of settings did you create follow-up visits? And then they have some other questions that go with it.
Okay. In our federally qualified health centers, they actually gave our interventionists an office, their own office. In some of the hospital settings for the return visits, they worked with, for example, they had HIV project there. They had a social worker in a physician's office that wasn't used on certain days. So those were the days that the healthcare educators would schedule the return visits with the patients. And when they did come back, a lot of the material that we used was out of the second edition of motivational interviewing. And for example, questionnaires were like long-term goals in your next 12 weeks. What are your long-term goals? What are your short-term goals? A lot of cognitive materials that we used for those sessions. But basically, it was working on the motivation, just getting to know that patient a little bit more. But it's the average, while I was still working there, the average sessions, return sessions, was 4. After 4, they were either doing well, or they were discharged, or maybe they had to be referred for further assessment.
Do you have any idea what the rate of the follow-up versus no-shows? And if a person didn't show up, did somebody reach out to them?
Yeah, because this is not your traditional drug and alcohol program, you were able to contact by phone that patient. Okay, you know, if the patient didn't answer the phone or whatever, you didn't leave. All they did was leave their name. They didn't leave who they were or where they're from, because the patient knew who that person was. Or part of the follow-up, if they didn't show, we would send out a little letter to them addressed specifically for them without the, if it was a hospital entity, it was okay to have the return address on it. But if it was a drug and alcohol treatment program, we did not put return addresses on there. I mean, you know, on the envelopes, so the confidentiality was maintained. But it was okay. Matter of fact, they're encouraged, especially the ones that we did follow up on, to even send out little cards for, you know, for their birthday, you know, different things like that. Because what we did is we had at each site, we had one of the healthcare educators to be the follow-up coordinator. They maintained a spreadsheet on that, because what was very important was I did quarterly site reviews. I had certain agenda that I had every 3 months that I would go in and go through, and one of them was the follow-up rates, and I would see their follow-up charts and see what they were doing, see what their contacts were, and I would help them with other things. I was part of their team. I didn't want them to say, well, here comes the state guy coming in, you know, but I was part of the team. But that's what was part of the thing. They were encouraged to send, they were required by SAMHSA to send out certain letters, but the things for the birthday, matter of fact, Christy, oh, she was there at IRETA. I'm trying to think of her last name. Anyhow, she had the idea of follow-up rates. That's what she does. She has a contract with a lot of the states, and she does a lot of the follow-up. And that's one of the processes, you know, sending them a nice little birthday card, a reminder about their return visit or their follow-up visit, but also for their return free treatment session. If they didn't show, you were able to call them and use the phone. And even on follow-ups, the only time that you could be using the thing is if they were up north. If, for example, we have snowbirds here, they go up north. If they're scheduled for a 6-month follow-up visit, they're not going to fly down here, but we have their information. We gathered their information and their release that we can contact them by phone and ask them the questions over the phone for the follow-up. So with this, there's a little more leeway with this project than there is with other, you know, programs, because it's not, you know, as a clinician, it would be for me to call a patient at home and talk to them at home is not, you know, status quo is something you should be doing, but with this it's a little bit different.
Are these follow-up brief treatments billable?
If they're still in your program,
Yeah.
not the 6 months follow-ups on, but the brief treatments are. And it all depends on your state, what your state's going to authorize, especially if you're billing Medicare. Because again, it's for, let me go back to this one slide up here. Oh, crap.
Now, Bob, just watch it.
Crap. Yep, I know. Oops. There we go. Here. Okay. See, like it up there, it says for your commercial insurance, alcohol substance abuse structure screening and brief intervention services, 15 to 30 minutes. Okay, then you have your alcohol or substance abuse structure screening and brief intervention services greater than 30 minutes. Our brief treatment sessions are considered what we call intensive, extensive brief interventions because they're anywhere from 30 to 40 minutes. So those are certain codes that you can be using. Now, it all depends on how much, say if it's an insurance program, as you know, the insurance programs only pay for so much. If it's your Medicare, Medicaid, they have their rules on that. So whatever state you're from, familiarize yourself and find out if your CPD codes are turned on for your state. especially for Medicare and Medicaid.
Okay. Here's another question. Did the practitioners who used SBIRT receive specialized training?
Yes. Yes, they do. They're required to go through initial training. Here, even when I was in Pennsylvania, we had a minimal of 2 days training. Here in Florida, we had 2 days initial training. Then we had we gave each area training on advanced motivational interviewing techniques, and I also provided mentoring to the sites if they needed it. And we had provided training every so often, and we had every year we had our SBIRT annual conference where we had training and everything for everyone, and it was mandatory for them to come, and we had it in their provider contracts that the training was covered, that they were required to come to these trainings.
Okay.
And then what we did is we developed competencies, and I developed a supervision checklist that after 3 months they do the checklist, and annually they do the supervision checklist with the SBIRT staff.
Okay, thank you.
It's very important for fidelity of your program.
Here's a question from a minister. He is a minister working in a hospice and substance abuse field. Wants to know if he can use SBIRT in his pastoral counseling.
Oh, definitely. Definitely. I trained, like I said, a couple of Catholic programs in Miami on this, on the screening tools, and also on the motivational interviewing techniques. These motivational interviewing techniques are helpful in any other area. And I can say that for myself because in my church I went through the training. I'm a Stephen minister, and these techniques are really great to use, especially the pros and cons, and using the confidence rulers, and talking about what their lifetime goals and how they're going to achieve that, and helping them lay out a plan on paper how to do that, and discussing their progress when they come back, using self-efficacy. It's really great. It's really great because there's a hierarchy in the church level. I found greater success because they have that belief in that higher power, just with the 12-step program, that higher power theory. That's vital, and I think it's a really great area to use the SBIRT model with.
Okay. And if people want any more information on motivational interviewing or any other SBIRT topics, we do have the webinar library at the IRETA website, and I'll send everybody a link to that tomorrow. We just recently did a 2-part webinar strictly on motivational interviewing, which could be helpful too. I've got one more question for you. Let's see. What would an SBIRT assessment packet look like for older adults? Like what kind of forms or assessments would you need in order to ensure that a comprehensive evaluation can be accomplished?
What is given to them, it all depends on the program. We have some mental health programs that are going into the home. They bring the PHQ-9 with them with the assist, and they just ask those questions, the screening questions. They don't use a pre-screen because they don't have to, because they're in the home and they're going to be there for at least an hour or better to do their intake. So you would need your forms. You would need the assist form. You would need your short version geriatric depression scale if you're doing 55 and above. If you're going to be doing all ages, use the PHQ-9, the patient health assessment form, instead of the SGDS, short version geriatric depression scale. Those are the key things to get your scores, to determine what intervention is going to be needed. Okay, so those are the key forms, and you can download those forms from my Redis site, from from the Florida website that I gave you. It would be the ASSIST, and it would be the short version geriatric depression scale. Those would be the key ones to get started, doing this project. And then, plus I said that people would need some training in the motivational interviewing skills.
Let's see, what type of information about SBIRT do you provide the client?
The client? Well, when they first come in, again, you're part of the health program there. If you're separated from that, you would share with them that you're going to be asking them some questions related to their health. Their project that we do here called BRITE. It's for older adults. It's to ask certain questions about your use of alcohol, prescription medications, because we know it can affect your health. And our primary concern while you're here is a healthy lifestyle for you and to succeed, in having a fulfilled, healthy life. And do you mind if we ask that? No. And then if that's part of your program, that's part of your program's intake packet. So when they sign their release for your intake packet, they're signing that release for those. Again, the confidentiality is based on the type program that you're working in. When you have the memorandum of understanding of the hospital and you're working in the hospital, remember that patient is the hospital's patient. It's not your patient. So they signed that agreement for the intake process, and you have that contract with them. And you're asking an extended health care. As a matter of fact, it's much easier if they provide that pre-screening form, the hospital does, because the pre-screening form is a extended health care questionnaire, and at the top it has the hospital's logo on it. Okay, so they complete that out and sign it themselves. And then when you're doing, you have to share with them the information about the GIPRA. If you're required to do the GIPRA, you're saying, I need to ask you some more questions related to your health and the use of the alcohol based on the information that you've already given me. And these questions are questions that are provided to the funder that helps us fund this program for just information. It's not shared with anyone else other than these individuals. So you have to talk about that if you're doing the GIPRA, because that data is going out of that hospital down to SAMHSA and CSAT. And SAMHSA and CSAT is not part of that hospital.
Okay. Yes, I have one comment and then one final question that we'll go through here. A comment is, it said there's also videos demonstrating motivational interviewing and SBIRT at the ENA.org site. That's Emergency Nurses Association. And we have links to quite a few of those short scenarios too, and I will include those in the website as well. So thank you, Paula, for giving us that ENA.org for videos. And somebody wants to know about GIPRA, and that's the government yeah, it's a recording act, and it's a form that you might have to fill out if you're required to do so. Okay, and there's one other question here. If you were going to start out small with a pilot SBIRT for older adults, what setting would you suggest? Which setting did you find it most successful with the older adult population?
I think the one that, if you're starting off small, if you have any local senior center programs where the seniors go there for movies, activities, maybe for medication, to fill their medication boxes or whatever, they're very helpful. We also, there was the people at the shelters, okay, where they would come in for lunch every day. Some of the programs started there, and they were very successful, and the people were willing to talk. And I think if you have a veterans organization, if you have like a county veterans administration, that would be a great place to go and get started, especially since it's a requirement for them to do some screenings, and you can bring it to the attention that about, you know, Miami VA. I'm sure there's other VAs throughout the other states that are now involved in this, but working with the veterans is really a good place. We get a lot of good feedback from the vets.
Okay,
and just a real quick one too on the Government Performance Reporting Act. That again is required for federal dollars. There's different ones, but for you, for SBIRT, if you are getting direct monies from the state that's coming from SAMHSA, you're required to do that on all the clients that you screen, the screen positive and negative actually. So that's a requirement. And another site too, Chris, is the BNI Art Institute from the Boston University Medical Center that has a lot of the, like the one that I use, has a lot of interventions and scenarios on their films.
Yes, they do have quite a few there, and I'll make sure everybody gets those links too. We're also getting to very good examples of a good interview and a bad interview from the trainers we work with in Georgia, and so those will be on our website as well. So it looks like we have a lot of information here. I really appreciate everybody's questions and comments and information that they've given, and especially to you, Bob, thank you so much for participating in this. We really appreciate the information. The slides are already on our webinar library at www.ireta.org/webinar library, and I'll give you that again tomorrow. And then this recorded webinar will also be on there to view again at a later date or to pass on to your coworkers if you'd like them to view it. So thank you, Bob. Thanks, everybody. At this time, I'm going to close the webinar off, and hopefully you'll join us again next month. Bye, everybody.